Hello, folks. Thank you for joining us today. We're going to wait just a few seconds while people enter the Zoom room, so we know that can take a little bit of time. So my name is Michelle Wagner, and I'm with NAMI New Hampshire, working on the first episode Psychosis Early Serious Mental Illness Initiative. Thank you for joining us for today's webinar titled Mission Zero and Care Traffic Control, a collaborative effort to eliminate emergency department boarding. This presentation is being recorded, and you'll be able to find it on the education page of onwardnh.org. In the next couple of days, you'll receive a follow-up email with links to both an evaluation and the recording. And if all goes as planned, when this Zoom meeting ends, you will go directly to that evaluation to fill out. This is a Zoom webinar, so your camera and microphone are off. The question and answer feature, that one is working, so please enter any comments or questions you have there. Our colleague Nancy Fennell, the director of the Behavioral Health Clinical Learning Collaborative, is with us to help field your questions. So now I'm going to turn it over to Susan Stearns, the executive director of NAMI New Hampshire, and she will introduce our presenters. Susan?
Thank you, Michelle. And welcome, everyone. It's a real pleasure to be able to introduce these presenters to you today. They are colleagues with whom we work closely here at NAMI New Hampshire. So I think you're all in for a treat as you get to hear about the work that they have been spearheading at the department and at New Hampshire Hospital. So Marissa Henn, who's joining us today, serves as the Deputy Commissioner of the New Hampshire Department of Health and Human Services, which is the state's largest executive agency, guided by the mission to join communities and families in providing opportunities for residents to achieve health and independence. In this role, she leads cross-cutting strategic efforts to integrate policy and practice with a focus on supporting New Hampshire's most vulnerable individuals. She also oversees Hampstead Hospital and Residential Treatment Facility, the state-run psychiatric treatment facility for youth. Marissa was recently promoted from the role of Associate Commissioner, where her portfolio included oversight of the Division of Children, Youth, and Families and the Division for Behavioral Health. Marissa has spent the past 15 years working to try and put community needs and voices at the center of health and human services system policy and design. We also have with us today our colleague, Ellen LaPointe. Ellen is the Chief Executive Officer of New Hampshire Hospital, where she spearheads initiatives that underscore the institution's pivotal role as the largest employer within the Division of Health and Human Services. Guided by a mission centered on aiding individuals with acute mental illness to stabilize and thrive, Ellen collaborates closely with the New Hampshire Hospital Executive Team and the Department of Health and Human Services Senior Executive Team. Together, they tirelessly pursue the hospital's vision of setting the standard for inpatient psychiatric care regionally and statewide. Drawing on her extensive background in long-term care, Ellen also assumes oversight of Glencliff Home in northern New Hampshire. At Glencliff, a nurturing environment fosters independence, dignity, and acceptance among its residents, embodying Ellen's commitment to compassionate healthcare. With nearly 2 decades of experience in healthcare leadership, Ellen is driven by a profound passion for serving vulnerable populations, ensuring those in need receive the care and support necessary for a fulfilling life journey. So welcome, Marissa and Ellen. We're so pleased to have you.
Great. Thank you so much, Susan. It's such an honor to be here. And before we dive into our presentation, just wanted to sort of ground us in how meaningful an opportunity this collaboration is for us as individuals. Also, we're proud to bring the engagement of the department and of New Hampshire Hospital, respectively. But really, this is a personal issue for so many of us. And just wanted to note that for me, I grew up in New Hampshire in a family that was deeply connected to community health and mental health. And it was when I was working in New York City government that someone sent me Anne Marie Timmons' article describing the conditions around emergency department boarding that were occurring at that time. And I was really struck working in this large city. You know, I understood why in New York ED boarding was an issue, just given the size and scale. But I was really surprised to hear that in a state I'd grown up in that I so associated with caring for vulnerable people and addressing the drivers of health, that this was an issue occurring every day, and that people were suffering, their families were in a place of such unknown about what was going to happen next. And so obviously this is an issue that's been with us for some time, but I think for all of us, the deep recognition that whether we ourselves or a family member or someone we serve through policy and programs is affected, this needs to end. It's time for emergency department boarding to be a thing of the past. And so it's just, the only way to do this is through deep collaboration with people who understand the system firsthand, as advocates, as hospitals. And so I think that's what we hope to share with you today, is a vision and approach for not tackling this simply as a department or as a state hospital, but as a community. And I'll let Ellen introduce herself while I pull up our slides.
Great, thank you, Marissa. That was beautifully said. In somewhat of a similar vein, I grew up here in New Hampshire, in the Lakes region. I've born and raised in our beautiful state, and also was part of a family as a youth who were employed in various aspects of healthcare. So it's always something that's been very meaningful to me in serving others who are in need in the healthcare arena. And when I was coming out of college, I had the opportunity to fall in love with long-term care, where I got some exposure to mental health care and needs as well, but was extremely pleased to be able to join the state about 4 years ago, my first 2 years as the chief operating officer here at New Hampshire Hospital, and the most recent 2 years as the CEO, in working amongst very dedicated professionals in meeting the needs of those with mental health concerns across the state. So I'm very humbled every single day to be able to work with the team members that we have here, and really meeting my life's goals and passion of serving others. I also have had some family members with lived experience, and I really hope that by dedicating my employment to serving those in need, that some of the challenges that they faced that I can recollect as a youth are not going to be the same challenges, or hopefully challenges that we're able to address collaboratively for the best outcomes. So I'm pleased to be able to be here, and I'm actually kicking us off in terms of our first few slides. But of course, just to recap, we are here today to talk about Mission Zero and care traffic control, and that's a collaborative effort to eliminate emergency department psychiatric boarding. Thanks, Marissa. So what makes ED boarding a challenge? So of course, we've spent a great deal of time and energy talking about, examining, and working on solutions to the behavioral health boarding crisis. As we know, the fixes are not quick, nor are they easy. But as Marissa has previously said, we must address the situation through statewide work by involving hospitals, community mental health centers, designated receiving facilities, rapid response, mobile crisis teams, peer support networks, and community advocates and participants, which is truly why we've asked all of you to join us today. And together, it's our hope that we're going to be creating an environment for improved patient care throughout the state of New Hampshire. Catching up. So understanding Mission Zero. Mission Zero embodies the commitment to timely access to behavioral health care. The work to address ED boarding reduction has been a top focus for the state of New Hampshire, as well as the Department of Health and Human Services, for a very long time. As outlined in New Hampshire's 10-year mental health plan, which many of you may be familiar with, Mission Zero is adding additional resources and attention to overcome this urgent and complex challenge in collaboration with community stakeholders. Oops, Sorry. New Hampshire's ED boarding challenge has 3 key issues that must be addressed at the same time. All of them are extremely important. The first being what we refer to as front door issues. The front door issues are those that when people in crisis go to the emergency department because they've been unable to get the right level of care in the community to address their needs, or may just not know where else to go to be able to have those needs met. So while they wait in EDs, there are inpatient supply and coordination challenges, which is the next step. People with acute psychiatric needs are often unable to be transferred into inpatient care due to a number of challenges, the biggest tending to be a shortage of beds as well as staffing challenges in those environments. And then what we refer to as the backdoor issue. People are staying longer in inpatient psychiatric facilities for a number of reasons. Many of them revolve around a lack of the right level of support that they may need in order to discharge back to the community in the safest way possible, which then prevents new admissions from being able to enter into the inpatient facility. DHHS has examined over 30 different initiatives. So how will we get this done? We looked at information from different systems, listened to these concerns of people in the community, and invested in how others are doing things across the country. Then we picked the 6 most effective and ready to go ideas to work on, which we'll review in the following slides. But just to outline them briefly, the first one being expansion of certified community behavioral health clinics. The second, community-based crisis stabilization. The third, which you'll hear a little bit more about from me later on in this presentation, care traffic control coordination. The fourth, expansion in DRF beds. Again, that's designated receiving facility beds. The fifth, expansion in care and step down in less restrictive settings. And the sixth, landlord incentives to expand places to remain for individuals to remain stably housed. I'd like to turn it over to Deputy Commissioner Henn to review some of these items in a little bit more detail. Marissa, you're on mute.
Thanks, Ellen. So the first one is expansion of the Certified Community Behavioral Health Clinic model. It's a big acronym soup as usual, but we call it CCBHC for short. And CCBHCs are a relatively new way of building on the strengths of our community behavioral health system, but by integrating a lot more services. So rather than substance use treatment, for example, and mental health treatment being separate, this is a one-stop way of serving individuals with an array of co-occurring needs. There's specific requirements for this, and I think one of the things that makes the CCBHC model stand out as other states have implemented it is the fact that it is taking a super comprehensive approach. It's setting quality standards in a very new and different way than we've done before, and there's a level of payment that really rewards the system for delivering value rather than just volume of services. And so a lot of other states have seen that this has increased access while also improving outcomes when it comes to things like emergency department visits and issues of rehospitalization after someone's had an inpatient stay. So we're really excited that the Greater Nashua Mental Health Center and the Mental Health Center of Greater Manchester are already working to become certified, and they have provisional certification through this Mission Zero effort. And more will be coming online in the months and years ahead. So really important model that incorporates the components of community behavioral health that we know make a really big difference statewide and across the country. Another component of that front door is community-based crisis stabilization. So you're probably familiar with our rapid response access point, which is the way that people can use a crisis phone number and text and chat mechanism, as well as at times have a mobile team deployed to a community-based setting. So So the phone, the place to call, the people to the team to respond, this is that third leg on the stool, which is an actual place to go as an alternative to hospitals, emergency departments, jails. So this is meant to be a short-term subacute level of care. And it's shown great promise. I previously worked in the state of Utah, and it was remarkable seeing the extent of demand and the ways in which this environment really served people at that time of crisis, oftentimes resulting in getting them connected with services so they don't even need a emergency department visit or an inpatient stay. And so really kind of meeting them where they're at. So as part of Mission Zero, the state has contracted with 2 community mental health centers, Lakes Region Mental Health Center in Laconia and the Center for Life Management in Derry. And they will be opening their sites for community-based crisis stabilization. And we expect to have 2 more centers launching in the early part of next year. So now we move into that middle area, middle driver of inpatient beds. So a lot of exciting work is going on here at both a sort of direct state level, but also through public-private partnership. So under Ellen's leadership, New Hampshire Hospital will be at full census of 185 patients being served by the end of this year, thanks to very active renovations that I can watch from outside my window here. We also have partners in Dartmouth Health, which is setting up its first 5 designated receiving facility beds, allowing actually our northernmost setting for involuntary psychiatric hospitalizations. That's coming online at the end of 2024. And then you may have heard about a project going on in southern New Hampshire that is led by Solution Health that will be actually adding an increase of 60 beds, a total of between 120 and 144 bed facility, really increasing the availability of care while meeting the needs of the most vulnerable. And so the state is supporting that project with an infusion of $15 million in funds. So lots of work to increase the supply of inpatient beds and to try to offer geographic diversity to those as well. So as Ellen said, one of the things that's important isn't just to get treatment to people who need it when they're experiencing an acute episode of care, but also to discharge them with appropriate supports into the most community-based setting possible. There are times, and everyone is familiar with this, when due to the lack of housing that is both a regional and nationwide challenge, as well as unavailability of support services, we end up with patients who are having longer stays than necessary at New Hampshire Hospital, which is not appropriate for them, nor for the patients who need to use those beds for their acute situation and need for inpatient care. So it's really about creating that appropriate and warm handoff so that people, upon receiving treatment, can live in the community with independence and have flourishing lives. So there's a number of different projects underway. We have 2 5-bed programs for people with co-occurring behavioral health issues and intellectual disability going online, both of which will be in Newport, New Hampshire. We also have 2 additional 5-bed properties that are being planned, and we should be able to announce in just a couple months. In addition, we have some individuals, including here on this campus, who require nursing home level of care. So they may have a high level of medical fragility in addition to their need for supportive services around behavioral health or intellectual developmental disability. And for that, we've already been able to transition a number of patients. We're going to have up to 16 transitioning to a community-based setting, or a more community-based setting, I should say, a less restrictive setting at Stratford County Nursing Home, with the ultimate vision of allowing those who are able to have a full return to the community. So that's been really important as a additional level of care for people with complex needs who, again, aren't needing to stay at New Hampshire Hospital and can be in a far more community-oriented setting. Also, as part of that backdoor, we recognize the dramatic shortage of housing in general, but also really supportive settings for people who may have needs, who may have future situations where their mental health issues escalate. So there's a really effective and promising program out there called the Affordable Housing Incentive Program, or AHIP, which Granite United Way and the Home for All Coalition has been piloting over the last several years. And so we are helping them to scale up further, adding an additional 25 beds that will most likely be located in the Seacoast region, as well as Belknap County and Merrimack County. So again, these will be incentives that are offered to Housing Bridge subsidy recipients, but incentives rather to the landlords, recognizing that people with mental health issues may require some additional supports and patience and tolerance from their landlords when it comes to things that get broken during an upset episode, or a little bit of extra patience with rent payments, et cetera. So it's really a community-oriented solution to making sure that we have available rental properties, but also some additional supports for people who may need it to stay stably housed and hopefully not require a rehospitalization. I'm going to send it back over to Ellen, who's leading another key component, which is care traffic control.
Thank you, Marissa. So care traffic control is near and dear to my heart. It is based here out of New Hampshire Hospital, and there's been a tremendous amount of collaborative efforts between the department and, of course, the hospital and many other participants to bring care traffic control into fruition. So a little bit about it. It was established here at New Hampshire Hospital in our admissions department. We have dedicated staff working on involuntary admissions and revocations for conditional discharge referrals requests, as well as placements into designated receiving facilities, up to and including in New Hampshire Hospital as a part of those options. Care traffic control, or CTC, as we're referring to it as, staffing includes psychiatric nurses, social workers, admission specialists, and business systems analyst roles. We also have participation by many other skilled team members here at New Hampshire Hospital, including the Chief Medical Officer, Director of Social Services, myself, and many other key participants. The soft launch of CTC started in mid-January of this year, and we plan for the full launch of care traffic control to be in about another month, around April 1st of 2024. Key component of what the full launch means is that 24/7, 365 days a year, that New Hampshire Hospital staff in the care traffic control department will be on site to make sure that these referrals are expedited the most efficiently and effectively as possible. Care traffic control is playing a key role in the Mission Zero initiative. CTC's primary role is to work with its partners in the emergency departments, in the community mental health centers, in the designated receiving facilities, as well as in houses of correction throughout the state, to facilitate the efficient movement of patients to the appropriate behavioral inpatient units, and to establish that our patients, who may also be our neighbors, our clients, our family members, our friends, and our colleagues, that they receive the most timely and appropriate care in what is often the most strenuous and challenging time in their life. Just a bit about the CTC admissions department overview. Patients who are psychiatrically stable enough for non-New Hampshire Hospital designated receiving facilities, so the other designated receiving facilities who we closely partner with throughout the state, will be matched preferentially to those designated receiving facilities as close to their home as possible. Of course, we know that those that have the closest access to their home and their community support and their family members is generally the most beneficial circumstance for the patients. Patients who are too medically complex for a standalone psychiatric facility will be matched to DRFs located within general medical hospitals as if possible, There are a portion of the designated receiving facilities that reside within or within extremely close proximity to other medical hospitals within the state. Patients that are too psychiatrically acute for other DRFs will be matched to New Hampshire Hospital, which many of you know is the most restrictive setting for a DRF within the state of New Hampshire. The admissions process includes reviewing the criteria and the process for matching patients to the appropriate facilities for their psychiatric care needs, and based on their clinical needs as well, and their level of stability at the time. The care traffic control team emphasizes the prioritization of matching patients to the most suitable facility while considering factors, as was previously mentioned, proximity to their home, their medical complexity, as well as their psychiatric acuity. So how do these efforts align with the existing strategies? You've heard us mention some of the strategies that are already in place here in New Hampshire. And of course, we want to create alignment with these strategies to really make sure that we're seamless in our provision and our ability to provide care. In summary, alongside of the needs identified in the 10-year mental health plan, New Hampshire is on a mission to make sure that everyone gets the support they need for their mental health and their mental wellness. We're building a system that cares about you as a whole person, including your family and your communities. Together, we can make mental health easier to find and to use for everyone. And just to orient folks to the graphic that's on the slide, of course, on the inside of the circle, those are the 6 different Mission Zero components that we've discussed today. And then, of course, on the outside, we are highlighting that we want to make sure we're having community-based services and treatment, step up and step down options, crisis and acute care, involvement, recovery and prevention, and early identification and intervention. Marissa?
You're muted, Marissa.
Not my day for unmuting. Thank you. I think in closing, before we open it up for questions and discussion, I just wanted to acknowledge that underlying the components of Mission Zero that you just heard a lot about is a philosophy that we need to work differently on this problem, that this is a problem of such complexity, or sometimes referred to as an adaptive challenge. And if you're familiar with adaptive leadership, there's a kind of guru of sorts named Ron Heifetz, who basically says that there are certain types of problems out there that require entirely new ways of operating. And I would make the case, and I'm happy to talk more about this in the discussion, that part of why we have not solved for emergency department boarding in the past is that we probably haven't treated it as the adaptive challenge that it truly is. And when it comes to tackling an adaptive leadership challenge, Heifetz writes that it can only be addressed through changes in people's priorities, beliefs, habits, and loyalties. Making progress requires going beyond any authoritative expertise to mobilize discovery. So what he means by that is it can't just be those of us in positions of leadership who say we have the answers, or those of us in positions of leadership who say this is what we're going to do. All of this needs to be done through truly dynamic collaboration and constantly questioning whether we're even diagnosing the problem right, let alone taking the right solutions to address that. And so happy to talk more about this, but I think part of why it's so appropriate for NAMI and others to be hosting this gathering today is that the whole governance structure for how we're holding ourselves accountable to what goes into Mission Zero and the progress and the success that it demonstrates is being done through a multi-sector coalition. So the state certainly has a seat at that table, but we also have advocates, we have community mental health centers. So we've got NAMI there, we've got the hospitals, we've got the Hospital Association, each of whom brings their voice. And we're constantly asking ourselves whether the voice and the experience of those who've actually been in our mental health system is being elevated adequately, because that's where we need to learn, and that's where we need to turn to see if we're actually making progress. So with that, and special thanks to those who organized this for putting together also a little glossary at the end, which is always so helpful, given how used to acronyms we are in the state. I think I'm going to stop sharing my screen and we would welcome questions or comments.
So there was a question in the Q&A, does CTC include minors? And Colleen, if you can please put your question in the Q&A, that would be terrific.
So that's a great question. At this point in time, care traffic control is generally focused on the adult population. However, New Hampshire Hospital works in close collaboration with Hampstead Hospital to make sure that the minors have the services that they need and the support in place to be able to ensure this process is happening seamlessly for that population as well. Marissa, with your oversight of Hampstead, did you want to expand upon that a little bit more?
Yeah, I mean, I think Mission Zero, to be honest, in this first phase is primarily focused on adults. Some of that relates to some of the underlying activities of courts to really get the state acting on this challenge. And so we wanted to bite off the right amount when it comes to solving. But I'll say two things. One is we don't intend to stop with adults. We won't really be successful until we recognize that this is an issue across the lifespan. So, and it's also an issue that's not just about involuntary hospitalization. It's also recognizing that people who may be open to hospitalization as a voluntary patient also face waits and are challenged in a fragmented system. So the ultimate aspiration is to be sort of one and all, but we wanted to start off with a scope that we thought we could make progress on. The other thing I'll say is we remain deeply, deeply committed to addressing youth behavioral health access challenges. One of the ways the state demonstrated that was by purchasing Hampstead Hospital, which previously partnered with New Hampshire Hospital in our state to provide services as a for-profit institution. And then about a year and a half ago, the state purchased that and gave it an entirely public mission. And so that, along with the addition of the psychiatric residential treatment facility and an array of other efforts that I won't bore you with now. So we're really, we're operating on parallel tracks, but very much intend to cross-pollinate and to allow the kind of rising tide of Mission Zero to ultimately lift all populations.
So that answers the second question, how do our pediatric patients work into this model? So you did that one for us. From Birgit, are the community-based crisis stabilization centers similar to the CSUs in Maine, and when will they open? If you happen to know what the CSUs are.
Does anyone know Maine system better? I admit I'm not. I don't want to misspeak because I'm not familiar. And I know sometimes crisis stabilization is used to describe more acute care. Ellen, you might be able to speak to this one. I can say I've been reading very eagerly about our neighbors to the south in Massachusetts, who very much have embraced a focus on this kind of 23.5-hour armchair model, and doing so kind of in conjunction with a rebuild of their community mental health system. And just in some media last week indicated that they've seen a substantial decline in ED boarding due to this expansion in crisis stabilization. But anyone familiar with CSUs or Maine who can add anything there? Okay, we'll have to look into that. So I'm eager to find out more.
Terrific. So this is from an anonymous attendee. Our understanding through current CCBHC work is that CCBHC, so that's Certified Community Behavioral Health Clinics, is a status that only applies to Medicaid recipients. I'm not sure how that impacts non-Medicaid, and they're looking for your thoughts on that.
That's a really good question. I mean, my understanding is that the entire clinic is certified as CCBHC, serving across the payer mix, but I wonder if the term is used in some cases, especially the payment mechanism to describe a Medicaid-only population. So that's gonna be another one I'm gonna write down and bring to some of our subject matter experts from the Division for Behavioral Health, kind of what are the implications of that designation when it comes to Medicaid versus non-Medicaid. So great question. Sorry, I don't have the answer.
And NAMI New Hampshire has been doing some work with stakeholder engagement around that CCBHC model. Ebony Martin has been working as the coordinator for that. So when you were talking about making sure the voices of those who are impacted are heard, that is part of the work that she has been doing, is traveling around the state and doing lots of virtual conversations as well to find out what's missing, what people want, what's working, what would help. Yeah, so work being done on that CCBHC model because it's very, very promising. We did have more questions coming in from Pierre. How does CTC, so the Care Traffic Control, work with the local community health service groups, WRT revocations? Who drives a revocation and how do family members access CTC support when local interaction challenges exist? That is local services reluctance to revoke due to bad press image or perception of them not doing their jobs.
Great questions. Thank you for asking. So CTC does work in very close collaboration. I'm actually just going to bring up that question again to have it in front of me. Oop, I lost it. That's okay.
Oh, sorry.
So clue me in if I missed parts of the opportunity to answer. So CTC does work in close collaboration with the community mental health systems, as well as, the network of hospitals and designated receiving facilities throughout the state. Oftentimes, not even just through CTC, but through other mechanisms, such as outreach that occur to New Hampshire Hospital in seeking of support. We also have circumstances where our Chief Medical Officer, Dr. Fetter, will be in close collaboration and communication with those that may have questions and really want to take a collaborative approach in making a decision about the next steps for a patient. So, for example, we may have a hospital reaching out to us saying, here's the circumstance with this patient, here's what we're thinking, but where you at New Hampshire Hospital are the expertise or the chief medical officer, what are your thoughts in terms of the best circumstances for this patient? Or same for designated receiving facilities through community mental health centers, either through our Director of Social Services, whose name is Cindy Labonis, or again, through Dr. Jeff Fetter. If there's questions or concerns or need to collaborate and create a little bit more clarity, then those avenues also exist, even outside of CTC. In terms of being able to provide outreach to those that may be in need, I know that there are several state mechanisms. I'm not going to get them right. I may look to you, Marissa, through 988 and through NAMI, of course, and other resources that may exist that I want to make sure those in need always know are at their disposal. But in terms of being able to reach out directly to New Hampshire Hospital, we're always here to try to help provide additional support and clarity as well. It is on somewhat of a relative frequency that we have those reaching out to New Hampshire Hospital to ask us questions, either via phone call. We also have a Office of Patient Experience here at New Hampshire Hospital. So we work in collaboration with them to make sure that when that outreach occurs, that those who are connecting with us have the way to get some answers and get a little bit of clarification. We may also reach out to our partners too, like I said, with NAMI or others, to be able to give those individuals the support they may need. Of course, because they're not generally an active patient with us at that time, but we want to be here to help.
Thank you, Ellen. Somebody else who also wants to be able to help is Colleen Amarina. She writes, she's with the VA Manchester for New Hampshire, that they have mental health discharge RN case managers. We coordinate with inpatient case managers at either emergency rooms to coordinate transfers to inpatient facilities or with inpatient units to coordinate aftercare. We wanted to just make you aware that we're available to help expedite a transfer with a VA Optum pre-auth if possible appropriate. We'd love to have a separate combo because they want to make sure that veterans are covered under this process. So, and then we have Colleen's contact information.
That's
Thank you,
great.
Colleen.
Colleen, thanks for that information. And I think this is what's been exciting to see with Care Traffic Control is how many partners have already come together to say, oh, we have ideas or we need to be informed about the changes in process, and then how many more we're learning about. So we'll make sure you're plugged in if that hasn't happened already.
Chris asks, are there any organizations out there that New Hampshire can collaborate with as far as new construction, housing for programs and services?
Yeah, that's a great question. I mean, the New Hampshire Housing Finance Administration tends to be sort of the hub for this and has been an important point of collaboration as we've worked on this. We specifically are working with, as I said, Granite United Way very closely on the landlord incentive part, but are open to more ideas that you all may have about other important developers, partners, sources of funding, because clearly the linkage between housing and addressing behavioral health needs and access is paramount. That's no longer something that is that folks don't see.
Thank you for that. Someone else asks, is there a plan to improve awareness about the changes throughout the state, specifically when options other than emergency departments are available to help with the transition away from the EDs for psychiatric emergencies?
Yes, that is key. There's no point in building something if people aren't aware of it. I think one thing that serves as a strength here is that as 988, as rapid response have grown, there's much greater public understanding of kind of the concept of crisis services. So I think it's about plugging into those existing campaigns and outreach that's happening. It's also about making sure we have the right people at the table when it comes, especially to first responders. So when I was working in Utah on parts of our crisis system, it's really important that we are thinking through if we want, for example, a site to be an alternative to a jail or to an emergency department for police. Police need to understand what that means. And does that mean anyone can be dropped off? Does it mean some people need a higher level of, medical or substance use screening before? So it's really, I think, again, about thinking through who are our first responders, and it's beyond kind of the typical mental health players at the table to kind of the broader community. And luckily, because of all the work that went on around the first components of crisis response, we have terrific existing coalitions. So lots more to do to educate and make people aware, but most other states that have set up crisis stabilization have seen no shortage of demand.
And one program that I'm thinking of are the step up, step down beds at the peer support agencies around the state. So to step up so they can avoid ending up in the emergency department and or to step down after discharge.
Absolutely.
Thank you. I do just want to go down to Colleen. She said the only community hospital DRF in New Hampshire, which is not in network for VA Optum, is Franklin and Concord. Just so folks are aware of that. How are the current crisis stabilization units in New Hampshire being staffed?
Yeah. So right now, while we're in this preliminary certification period, it's really building on the existing CMHC, Community Mental Health Center model and contract. So in the same way that when our community health center partners are adding, expanding, changing their model, it's the same organizational approach and shifting and attracting of resources. Ultimately, what this preliminary certification will prepare the state to do is to be eligible for a demonstration grant where we get an infusion of actual major funding, and many of those mechanisms, as I said, for value-based payment would go into effect. So the long and short of it is that for right now, we're sort of building on top of the additional work that that community mental health centers are doing, and it's built into their contracts from a state perspective. Over time, new resources and new components of the model will be built out as we pave our way into scaling this up through a demonstration project. We also have really great technical assistance on the crisis stabilization models through SAMHSA, and so, which is the Federal Substance Abuse and Mental Health Administration, so basically our federal mental health agency. And so I don't know the answer to the other question that was posed around financials, whether that's something that our technical assistance teams are looking at, because clearly the flow of dollars and recognizing the complex challenges that our community mental health centers are dealing with, especially in the context of Medicaid Unwind, like there's a lot that they are shouldering already. And so making sure we're being sensitive to that in working with them and not overloading them with an expectation of having to do everything without adequate support and resource. So I think more to come as we evaluate this preliminary phase and move into the demonstration period.
And workforce development efforts around the state for behavioral health. We know this is an issue across the board, not just for those crisis stabilization units. So
Absolutely.
Yeah.
a larger issue for sure.
Yeah. Do you want to say anything on that, Ellen, just from your firsthand experience, and then we can
Sure.
talk about
Yeah, I mean, New Hampshire Hospital obviously working very hard on our recruitment and retention activities, but so is the department in terms of partnering with the vast amount of statewide initiatives that are occurring around healthcare and behavioral health workforce development. Really excited about those partnerships so that we can all work together to solve some of these concerns instead of kind of competing against one another, which has been the case for some time. So, yeah, I mean, I think that's in a nutshell that it is an issue in New Hampshire. We know it is. Thankfully, in the most recent months, kind of post the most significant challenges with the pandemic, that we have seen an increase in some of our staffing levels in this environment. We are employing, obviously, agency staffing folks as well. So we're getting there, and again, eager to participate in more of the statewide initiatives so that we can all support one another with that need.
Excellent. Thank you.
I was just going to add one other thing, which is that investing in the peer workforce is something that we've heard very loud. And in addition to a sort of separate but connected strategy for expanding peer workforce, we're just beginning to implement some of the peer certification models and others, because we know that no state is going to succeed by begging psychiatrists and psychologists to come move to New Hampshire, as lovely a place as it is. We need to be much more creative in thinking about the ways to get our peers supported and trained up to be, offering their expertise, but also, what's the appropriate use of telemodels? Are we using telehealth in the right way when it comes to increasing access? So lots of that going on. And even within that multi-sector steering committee, that was actually our last meeting. We said, what are we missing in Mission Zero right now? And the sort of unanimous sense was we probably should be doing more on workforce. And so I think we bring a lot of humility to saying that's true. We can build a lot of these brick and mortar beds and housing and so forth, but if you don't have people to actually work them, then we have a problem. So we're going to try to be even more intentional about that moving forward.
So a couple of things in relation to that. The first cohort is just finishing up for this online certified peer support specialist training, right? So yes, I have someone who I love who is in that training, and that's been very successful. And then someone also adds, is this where interstate compact for licensed behavioral health professionals would be helpful if passed?
Absolutely. And luckily there's really tremendous work happening through Health Force New Hampshire, through some of the work of Giving Care that grew out of that report. But that's exactly right, is thinking through what are some of the also administrative barriers that could be lowered to help people who bring skills and talents to our state, kind of working at the top of their skill and licensure level. So So more to come there. On the kids side, I'll just mention, we're also thinking very creatively about how to increase workforce and services around youth behavioral health, and very much envision that Hampstead campus in the future as being part of that pipeline. So how do we build not just a additional number of inpatient beds at Hampstead, but really a campus center of excellence that is providing training and building on the pipeline of trainees who can advance their careers in New Hampshire.
In similar vein, we have several academic practice partnerships and a lot of effort being put into improving the quality of training, not just the quantity of the trainees that we have. And New Hampshire Hospital also is invested in being a hub and a resource for mental health education in the coming months and years. So we're really excited to be able to continue to expand the knowledge and expertise that exists here in New Hampshire Hospital and in partnership with Dartmouth Health to be able to really enhance workforce quality as well.
Excellent. Kevin does write, step up, step down programs have long wait lists. So that is of concern. And as someone whose loved one has used Step Up, I know that it was highly effective for him. So thoughts about expanding that program potentially?
Yes. Yes. I mean, I think we need all of it. And I think part of it is understanding like what the barriers are right now. Is it staffing? Is it bricks and mortar location and development? Is it coordination like CTC? And so I think that's part of what, one of the things we didn't talk about today, but is I hope a year from now or 6 months from now is that we're trying to be very data driven in how we examine what progress we're making and what barriers we're facing. So it's one thing for us to say that we're going to address these front door issues, these inpatient supply and the back door issue, but we need to prove it. We need to hold ourselves accountable and say, to that notion of an adaptive challenge, like, was our hypothesis correct? Like by moving the needle on this area, did we actually yield the improvement that we thought? And so what we are actually doing is also bringing together a work group of data scientists and analysts from different organizations to build a public dashboard that will help us to see some of the progress and some of the bottlenecks. And so it's, that's really important because otherwise, just going by our best hunch that like the way to reduce time in the emergency department is by better coordinating available beds. Well, what if it's also about something else? What if it's about some sort of documentation issue that's happening up front, or it's about the intake process within the emergency department? Like we need to be able to drill down to seeing this as a fuller system. And so taking that data-driven approach is sort of also the next phase of maturation so that we can understand what's driving some of these long waits at different parts of the continuum.
This is why the collaboration is so important. Right. And you both have offered for folks to have your email address. I'll put mine in here as well, in case they want to reach out to you with additional questions or comments.
Yeah.
I know we did already touch on law enforcement and first responders. Rebecca does ask, does law enforcement collaborate with the CTC regarding mental health and protective custody cases?
Yes, and not only just with the CTC, but with the hospital in general. We also have the SOC, State Office Complex Police, who are licensed officers in the state of New Hampshire and support this campus and have their headquarters here at New Hampshire Hospital. So there is a tremendous amount of collaboration between the police and the hospital, and obviously wanting to have the utmost respect and understanding around how that integrates with patient care as well. So that's very important to us to keep in mind. And I would also add that in particular to CTC and Mission Zero, we do intend to have a stakeholder conversation with them as well. They are in the loop with some of this work, but just like we are reaching out to all of you today, as very important key stakeholders in this process, we're going to be continuing to do that as we move forward with other stakeholders as well.
Excellent. Thank you, Ellen. Pierre says, excited to see the holistic expansion of services across the entire care spectrum. Has an expansion of extended transitional housing being considered for acute care patients that don't fit a release to affordable housing with only limited community support services? So a more intense level of supported housing?
Yeah, well, I mean, first of all, I think on our campus, that's already a pretty big offering, if I'm understanding the description correctly, of understanding that there are some people for whom it supports, you know, who even with all the right supports that we could offer in the community still might not be able to live independently. And so that's something we're taking a close look at, is how do we maximize while keeping some of those transitional housing options right-sized and small. How do we make sure that partners that we work with really closely, like NFI here on this campus, who own and run many of the transitional housing, that we, you know, how do we make sure that we're maximizing their support and looking for, we actually will hopefully in the next few weeks, if some of our governor and council asks go as hope next week, we should have an additional transitional housing program to announce also. So I think this is why we want to make sure we have our emails in the chat, because we're open to all creative ideas and partnerships. There's really some of this happens through, you know, deliberate strategizing together, and some of it has happened very serendipitously by someone coming and saying, I have an idea, or I have a funder, or I have, you know, two groups that really should talk to one another. So we're very open to that serendipity and ideas that you all bring, because it's sort of the only way that we're going to approach this differently than we have in the past.
That sounds great. And you said right sized, because I was paying attention when you were talking. All of the programs are small in size, right? Rather than 100 or 200 beds or apartments or.
Yeah, our federal government advocates, size does matter when it comes to providing services in transitional and community-based settings. It matters for federal reimbursement. It matters for people's safety and well-being. And so ensuring that, you know, we are supporting people in the most home-like context, while also realizing that that does present sometimes challenges around workforce and other economies of scale. So hence the reason why it's not, if only we could build just one giant apartment building, but that wouldn't serve people well either, right? It's not so simple. And I think we've seen governments sometimes have good intentions that have not always served people and communities well by thinking you can find a silver bullet like that. But I think in our state and in our situation, it's going to have to be many efforts happening simultaneously, tailored to the people in the community whom they're serving.
That makes sense. So as we're coming to the end of our time, we're talking about birthing new processes and programs, right? So patience with that. We're gonna have to ask the people in the state of New Hampshire for patience. And what words of wisdom, what takeaways do you have for our folks listening today, Marissa and Ellen?
I mean, I would just say, as evidenced by the sophistication of the questions that we're seeing here, many of which have stumped us, and I have a notepad full of follow-ups. I mean, keep challenging us, keep asking hard questions. It's really the only way we can improve is by bringing diverse perspectives. And we don't mean that in a sort of lip service way. Like, we need to poke holes in some of the ideas and strategies we have if they're going to actually be successful. There's no point in just sort of having a nice pamphlet or PowerPoint. This needs to actually achieve the task at hand, and that's only going to happen if folks like yourselves bring to us the critical feedback. So seriously, use those email addresses and know that we'll be following up on even some of what your questions have raised for us here today. Excellent.
Thank you, Marissa. Ellen, how about you?
I would completely echo what Marissa's thoughts are, and I would just add, change is upon us. We know that it's needed. We're excited about these opportunities, and I truly am humbled to be a part of what I feel is a monumental time in terms of behavioral and mental health in our state. And I really am excited about our continued partnerships with all of you and getting those questions to us so that we can really make sure that we're making informed decisions for everyone's best benefit.
Thank you for that. And thank you both for being with us today. Thank you, Susan Stearns and Nancy Fennell as well. That is the end of our time. Just a reminder, a recording of today's discussion will be posted on the education page of onwardnh.org, along with a PDF of the slides. Folks attending will receive an email in the next couple of days, which will include links for the website along with the evaluation if you can't do it after this. Once you've completed the survey, you'll automatically receive a certificate of attendance. For questions or comments, please reach out to me, mwagner@naminh.org. We look forward to seeing you next time. We're going to be talking about marijuana, so please don't miss it. And until then, take care. Thank you for joining us.